happy evening, a very good evening. Am I audible and visible? Am I audible and visible, guys? At least I am not able to see the audio visual. Can you please tell me whether it's all good? I don't know why am I not able to see. Yes, it's good. Okay, thank you so much. So yes, guys, like if you attended the yesterday's session, the special class where we discussed some clinical integrated MCQs in radiology. Today we have radiology Pictionary. So when I say Pictionary, it takes me back to my MBBS days, where in the college fest we used to have this Pictionary game which we used to play. So similarly, these are the images that you have to identify. You don't have the options here. So because I want to see who gets this right, and so I have made your task easier by putting the cases, the challenging cases in pediatric radiology. They are, clinically they are very important, practically they are very important. It's just that how do they look on radiological images that we need to identify, right? So some very, very interesting logical conceptual cases, that is what we are going to see. And before that, I want to make sure that you all are aware of the Plus and Iconic subscription. And most important, on 10th July at 8 p.m. you have your MedMind scholarship test. The topic is one topic itself, pathology slides. So unlike your final exam, 19 subjects nahi hai, you have only one topic, pathology slides, and you have various scholarships up to 100% if you are in the top 19-20 ranks. All right, and so you also have your 3+1 and 12+2 going on, and the 4-year subscription is something that we have introduced recently, taking into consideration the first year and second year MBBS students. Raise a hand, a feature that I am using now in my Plus classes. So there is ongoing Radiology Plus course that is going on for the FMG December 2021 exam, but the NEET PG students are also attending, and we are utilizing it like we are enjoying it. We have rapid fire questions discussion, so all the Plus subscribers can join in tomorrow and see how does that raise a hand feature work and how we have the rapid fire quiz there. Yes, and the new batches are starting on 7th of July, the Focus FMG batch, the Last Mile to NEET PG Next 2022 batch, all batches starting on 7th. And when you are coming to the platform, be for the free live classes or be for the subscription, you can use my code Dr. Nikita Live, right? And I'll be hoping to see you all on the Unacademy app as well. Now coming to your, the cases, the challenging cases. Here it goes. This is the first one. You have the clinical history that makes your task easy, and you need to identify what do you think is the diagnosis here. So let me label this your image A, your image B, and your image C. What do you think is the diagnosis here? Kya baat hai, amazing. So Valentidium coli has got it right the first. So you have a 1-year-old child with an abdominal mass. 1-year-old child with abdominal mass. Start thinking first of your neuroblastoma any which ways. Most common extracranial mass in the child is your neuroblastoma. There is focal swelling of the right temple. So you have right temple ka swelling. There is anemia and there is elevated urinary catecholamine. This gives away the diagnosis. The elevated urinary catecholamine, this gives away the diagnosis of neuroblastoma. But my question here is, tell me, what do you see in this first image? Image A, is it normal or do you see any pathology anywhere? Where do you see the pathology? Tell me the location. In the image A, is it the right side? Is it the left side? Where are you seeing the pathology? In the image A. So we are not talking about image B or C yet. It is the image A. So very correct. Now if I show you this image, let me zoom this and show this first image to you. So this one, if you see very carefully, this is your right paraspinal mass. Very correct. This is the right side. So first let's get our basics right, that what is your left side is the patient's right side. So this is on the right side, the right paravertebral lesion. What do you think? What is this lesion showing? That is calcification. The white area, white like the bone, that is calcification. When you see the further images, tell me what all findings are you seeing in this second image? So there is this mass here, right? There is this mass here. What is the mass showing? These white areas are the calcification. Very correct. It is encasing the vessel. So look at how it is encasing the vessel. Other important feature of neuroblastoma versus Wilms tumor. Look at how it is crossing the midline. It has gone to the other side, right? So it is crossing the midline, calcification, encasing the vessel. Any other finding here? Any other finding here apart from the mass? Any other finding? Look at the other organs as well. Look at the other organs. Any other finding? Yes, absolutely right. So there is your left hydronephrosis. So in one case, basically you are getting to learn many points. So एक है आपका, this is how calcification looks like. Look at the left kidney. Look at this gray color fluid. That is your hydronephrosis. So there is left hydronephrosis as well. And in this image C, what are we seeing in this image C? So clinical scenario में बताया गया था कि right temple पे swelling है. So look at the region, the right temporal region basically here. So look at this one. What are we seeing here? There is this metastasis. Skull metastasis is very common. Bone metastasis is very common in that skull metastasis. And look at the sunburst type periosteal reaction. The sunburst periosteal reaction with the bone metastasis, associated soft tissue. These are the findings that we are seeing here. So if I have to write down the findings that we are seeing here, so this is the mass on the right side with the calcification, right paraspinal mass. In the second image, this entire thing is the mass showing the calcification encasing the vessel, and we have the left hydronephrosis, and this is the metastasis here. So what are the features of neuroblastoma versus Wilms? Now Wilms arises from the kidney, so you cannot separate the kidney from the mass. Here the kidney is seen separately. Neuroblastoma, as you see here, remember this index case, it crosses the midline. Wilms does not cross the midline. This encases the vessel. Wilms displaces the vessels, right? In neuroblastoma, you have bone metastasis, which is common. In Wilms, it is your lung metastasis which is more common. It is your lung metastasis which is more common. And you have catechol amines which will be elevated. Can you tell me what scintigraphy can we do for your patients of neuroblastoma? What scintigraphy can we do in a patient of neuroblastoma? Which nuclear scan can we do? Very correct. It is your MIBG scan. It is your MIBG scan. MIBG, it is radio labeled with iodine 123. MIBG scan. So anywhere where you have your increased catechol amines, the tumor secreting catechol amines, in that case we can do your MIBG scan. But remember that your MIBG can be normal in a patient of neuroblastoma. हमेशा पॉजिटिव आएगा ऐसा नहीं है. Okay, so remember MIBG scan can be done. And what staging histology में हम ये क्यों ऐसा हो गया? Just give me a moment. Yes. So what staging do we use? Your histopath? Histological staging of neuroblastoma. What is that name? What is that name of the system that is used? The Shimada system. This is a previously asked question, so you should know this. That is your Shimada system. Okay, that is your Shimada system which is used. And the gene which is there is your NMYC gene. Okay, that is your NMYC gene in your neuroblastoma. You have CMYC gene in Burkitt's lymphoma. And where do you have your LMYC gene? L for lung cancer, the small cell lung carcinoma, right? The small cell lung carcinoma. So this is about your neuroblastoma. Okay, that's your neuroblastoma. Very, very important to remember. Let's go to the next case. Okay, so get ready for the next case here. This is a newborn infant with acute decompensation. So the diagnosis is simple, but the image might be a bit difficult. If you are finding it difficult to see the findings, let me zoom this image and see whether you can see any pathology here. Okay, so I am taking the image here. All right. No, this is not transient tachypnea of newborn. This is acute decompensation. Okay. No, not single bubble, not CHPS, not figure of 8. Okay, let me give you the clue here. So when you are not able to identify, I'll give you the clue. So the finding, the pathology is not in the chest. The pathology is in the abdomen. The pathology is in the abdomen. So another clue if you want me to give. Okay, very good. So very good. Rachna has picked it up. That is your football sign जो हमको दिख रहा है. So Rachna has picked it up. That is your football sign. Now where is the football sign here? Okay, where is the football sign here? Again, let me zoom this and show you this image. So football sign is seen in massive pneumoperitoneum in the supine radiograph, and it is generally more commonly seen in your infants and children. So this area which you see here in the epigastric region, here in the center, this lucency that we are seeing, that is your football. And can you see this white line? Can you see this football में white line? जैसे आपका football होता है उसमें वो stripes होते हैं. This is your ligament which is surrounded by air on either side. So that is the distinct ligament that we are seeing here. So this is the football sign in the supine radiograph, air collecting here, and you see the ligament. Another important clue here which tells you कि भाई यहाँ पे obstruction भी हो सकता है, distal obstruction. Look at the rectum. Always in a patient where pneumoperitoneum obstruction, look at the rectum. Okay, your rectal gas is absent. Your rectal gas is absent, which tells you that there might be obstruction somewhere, which has then led to your pneumoperitoneum. So absent rectal gas is another feature suggesting your obstruction. So this is basically your football sign here, the air lucency in the center. This is the ligament outlined by air, and you have the absent rectal gas. Okay, and you have the absent rectal gas. All these are features suggestive of pneumoperitoneum. Okay, all these are features suggestive of pneumoperitoneum. Pneumoperitoneum, what decubitus X-ray do we take? A previously asked question again. In pneumoperitoneum, will you do right lateral decubitus or left lateral decubitus? So always remember that it is your left lateral decubitus. When you do left lateral decubitus, the air will rise to the right side. The liver on the right side will give a good contrast to the black air. If you do right lateral decubitus, air will go to the left side. So it might be difficult to identify the free air and differentiate it from the colonic air. So always remember it is your left lateral decubitus. With a horizontal beam or a vertical beam? With a horizontal beam or a vertical beam? With a horizontal beam of X-ray. Always with decubitus, the X-ray beam comes horizontal. If the patient is like this, horizontal beam, not the vertical beam. Okay, remember, always it's your horizontal beam. Pneumoperitoneum. Tell me quickly some other signs in pneumoperitoneum in X-ray. You have the Wriggler's sign, not the Wriggler's triad. Wriggler's triad is in gallstone ileus. One we saw here, that is your football sign. What other signs do we have? You have the cupola sign. All of this we have discussed in our plus classes. Air beneath the central diaphragm. Wriggler's, football, cupola. You have your telltale triangle sign. Right, in between the bowel loops, you have the triangular accumulation of air. And what is your Doge cap sign? Where do you see the air in your Doge cap sign? In between the liver and the kidney, basically in the Morrison's pouch, the hepatorenal pouch, right? And you can see all the ligament signs, air surrounding the ligament. You can get your falciform ligament sign, you can get your urachus sign, and when it surrounds your umbilical ligament, it can give your inverted V sign. Okay, remember this is also important. It can give your inverted V sign. Okay, the inverted V sign. That's amazing. Okay, so pneumoperitoneum ke signs important hai. And what is the most sensitive investigation for pneumoperitoneum? What is the most sensitive investigation for pneumoperitoneum? Please remember, anywhere when it's a pathology containing air, for air it is always your CT scan. Okay, for air it is your CT scan. Most sensitive, first will be X-ray, but most sensitive is your CT scan. Okay, it's your CT scan. Alright, so done with the second case, football sign, what it was, pediatric radiology. Let's go to the third one. I am sure many of you will be able to identify this. So a 8-year-old female with history of recurrent lung pneumonias that does not ever clear completely. Very good. That's great. So Ritvik has answered it first. This is your PAPVC, that is your Shimitar syndrome also that we are seeing here. Now this is your Shimitar sign. This is your Shimitar sign. Atelectasis, हाँ. But most important finding क्या दिख रहा है यहाँ पे? Look at the X-ray, look at the CT scan. So in the radiograph, okay, in the radiograph. So first of all, one thing that I want to clear here, please remember that this is the X-ray which is placed normally. Your L is on the left side, that is your right side. L सीधा है कि L उल्टा है, उससे फर्क नहीं पड़ता है. The L has to be on the left side of the patient, that is your right side. Now look at this, if you can see this linear opacity जैसी चीज यहाँ दिख रही है. Look at this one. This linear opacity that we are seeing here going downwards inferomedially. Look at the slight deviation of the heart to the right. Look at the comparatively small right lung as compared to the left lung. So Shimitar syndrome is also called as hypogenetic lung, and it is most commonly seen on the right side, not on the left side. Similarly here, this is the CT scan. You can see the white bone cortex. What is this structure here on the CT scan? What is this structure? This is the aorta. Okay, this is the aorta. This is the aorta going down. And this is your right side ka pulmonary vein. The right pulmonary vein going into the IVC. You have the liver. Usme se aa raha hai IVC. So this generally goes into IVC, though it might go into hepatic vein or anywhere else, but most common it is into the IVC. Your pulmonary vein should ideally drain into the left atrium, but rather than going into the left atrium, it is going into the IVC. So that is your anomalous pulmonary venous connection, and it's only on the right side, not on the left side. That is why it is your partial anomalous pulmonary venous connection. Along with the hypogenetic right lung, the heart shifted here. This is called as your hypogenetic lung syndrome. Okay, this is called as your hypogenetic lung syndrome or your Shimitar syndrome. Shimitar basically means a Turkish sword. This is how it is having the sword-like appearance, the Turkish sword appearance, Shimitar sign. Now you have the infantile type, you have the adult type. Infantile type is the one which is more severe and it is associated with your other cardiac anomalies as well. So we should always test for other cardiac anomalies as well, and the patient can present with recurrent right lung pneumonias that do not clear. Okay. Another important differential when you have a patient with recurrent pneumonias that do not clear in the pediatric age group, again also remember your pulmonary sequestration. Okay, also remember your pulmonary sequestration. Pulmonary sequestration, what do you mean by that? A part of the lung which is sequestered, separate from the rest of the lung. How do you diagnose pulmonary sequestration? What is the most important thing? Very correct. That is your CT angio. Why CT angio? Because in sequestration, it is not supplied by the pulmonary artery. That part of the lung has your systemic supply from the aorta or a branch of the aorta. So you want to prove that it is supplied by the aorta, and that is why CT angio is the investigation. Okay, CT angio is the investigation that we do. So remember, this is your Shimitar syndrome. Okay, partial anomalous pulmonary venous connection. Let's go to the next one now. Okay, let's go to the next one. Okay, this might be a bit tricky. Let us see if you can identify this. This is a newborn with abdominal distension. This is a newborn with abdominal distension. It's a bit tricky here. Okay, this is not necrotizing enterocolitis. When you have necrotizing enterocolitis, either it can be normal in the early stages, you will get your pneumatosis intestinalis वगैरह, वो सब यहाँ नहीं दिख रहा है. Now, not even midgut volvulus, so you will never be able to identify like straight away midgut volvulus on a plain abdominal radiograph. Someone has mentioned it very close. So Raj Ravi is very close there, and this is not the colon which is dilated. Okay, this is not the colon which you see dilated. Hirschsprung's bhi nahi hai. Someone just rightly mentioned. Okay, so this is very close. Raj Ravi had mentioned, then Preet, and you have SD. So let me tell you what are the findings that we are seeing here. The obvious thing that we are seeing here are this gaseous distension of the bowel loops. हमको यहाँ पे gaseous distension दिख रहा है bowel loops में. Let me focus this here. Let me focus this. Now can you identify something here? Can you see something here in the right lower quadrant? Is it clear now? What is this area that we are seeing here, white? That is your calcification. At least that is what I want to see. Yes, Riya, absolutely right, Rachna, Riya. You can see this calcification here. So when you see this distension of the bowel loops along with this calcification, punctate, or it can be this chunky lobulated calcification like this, remember in the newborn, think of the diagnosis of meconium. It is your meconium peritonitis. Okay, it is your meconium peritonitis, not meconium ileus. In your meconium ileus, your colon will be small. There will be other findings. Soap bubble findings would be seen in the bowel loop. Here there is no soap bubble in the bowel loop. There is no microcolon. This is your meconium peritonitis. Now what is meconium peritonitis? Meconium peritonitis is when in utero, that is under he, the fetus has, the meconium has gone out of the bowel loop, perforation, okay, meconium has gone out. So this is the meconium which has gone out and it is calcified. It can form like a pseudocyst like structure. You might see the calcification surrounding the pseudocyst. You might see this punctate calcification, and you see this gaseous distension of the bowel loops. So it could be an obstructive cause or it could be because of some other causes as well. So remember, this is in utero perforation. So meconium bahar chale gaya. That meconium is getting calcified. So this is the most important clue to identify your meconium peritonitis. Calcification along with the distended bowel loops. Okay, calcification along with the distended bowel loops. This is your meconium peritonitis. Alright. Yes. In your meconium ileus, जब हम बोलते हैं there is meconium ileus. Now, basically the meconium is not going ahead and that is causing the ileus, the dilatation of the bowel loops. Why is the meconium not going ahead? Because it is very, very viscous. It is associated with which condition? It is associated like with your cystic fibrosis, where there is the secretions are very, very viscous. Now, since your meconium is not going ahead, it is not going into the colon. So basically your colon is not getting stimulated to develop. So colon develop nahi ho raha hai. That is why the size of the colon will be small. So remember, we get microcolon, while in your Hirschsprung's disease we get megacolon, right? There we get your megacolon. And since in the bowel loop you have meconium along with air, they are mixed together, that gives the soap bubble appearance. Okay, the soap bubble appearance on abdominal x-ray, that is your meconium ileus. Is this clear with everyone? Right? So this is your meconium peritonitis. Meconium peritonitis. So till now we saw your neuroblastoma, we saw Shimitar, and we saw pneumoperitoneum. I think we have one more case to go. So neuroblastoma dekha, pneumoperitoneum football sign, Shimitar, we have seen meconium peritonitis, and this is the final case. So I've got top 5 cases in pediatric radiology. So this is a 1-year-old with acute onset of wheezing. Now the history is very, very significant to help you think of what can be the diagnosis. Very good. That is your, very good Ritvik, that is your foreign body. But tell me, foreign body on which side? Is it the right side or is it the left side? Which airway? Right side airway or left side airway? Very correct. It is your left sided. Okay, this is your left sided. Now, whenever in a child you have acute wheezing, you have acute breathlessness, they give you history that the child was playing with the siblings, with the friends. Just give me a moment. Right. The child was playing and suddenly the child developed breathlessness. Think of the child as, aspiration ho raha hai. So that is your foreign body aspiration. That leads to acute onset of wheezing. In many cases, it is not necessary हमेशा कि बहुत acute breathlessness होगा. We have seen 1-2 cases in the pediatric age group कि that foreign body went unnoticed and it was discovered like after some time. The patient might have recurrent pneumonias and all of that. So even in your x-rays, it's not necessary. You will be always be able to pick them up. If your radiographs are normal, it's always better to go and do bronchoscopy. If the clinical suspicion is high and radiologically it is negative, be it on x-ray or be it on CT scan, it's always better to go ahead and do a bronchoscopy and rule out your foreign body. And here in this case, this is your inspiratory view of x-ray and this is the expiratory chest x-ray view. Now, expiratory chest x-ray view, how does this help us? Understand the concept. This is very, very conceptual. Now, in your inspiration and in your expiration, how is the normal lung on the x-ray? Inspiration, the air we are taking in. So that is, air is black on x-ray. So the lung is black in color. In your expiration, normal lung, should it become more black or should it become more white? Should it become more black or should it become more white in your expiration? With expiration, the lung should become more white because expiration, air is going out, the black part is going out. So the lung should become more white. Now, what will you see in an obstructed lung, an acutely obstructed lung, to be very specific? Acute obstruction जो हो रहा है, the air is trapped inside, so the lung will be black. In expiration, the air is not able to go out because it is obstructed. So will this obstructed lung become white? It will not become white, it will stay black, because basically the air is trapped and it is not able to go out. So black lung even on expiration, that is an indication of your foreign body on that side. So look at this image. Even in the inspiratory view, if you see, the left-sided lung appears more black, more lucent as compared to the right-sided lung. When you see this expiratory view, look at how as compared to inspiration, the right-sided lung is becoming more white. Look at this lung more black, this it is more white. That means this is normal. Look at this lung, it is not becoming white. Plus you see that some mediastinal shift is happening because it is hyper expanded. So this is the clue that there is the obstruction on the left side. Even though we know that obstruction, the foreign body goes more commonly on the right side because the right bronchus is in line with the trachea. But it's not that it cannot go on the left side. It can go on the left side as well. So very, very important to take your expiratory view. Where else do we take the expiratory view? Where else do we take the expiratory view of chest x-ray? One we said, जो हमने देखा already, foreign body. Second one, very, very important, yes, very correct, that is pneumothorax. Now this is again a frequently asked question in your exam. Why do we do a expiratory view in your pneumothorax? Now understand the concept. This is the black lung, this is the surrounding black pneumothorax. In your inspiration, in your expiration, what happens? In inspiration, we said that the normal lung is black because there is air. In expiration, what happens in expiration to normal lung? It becomes white. Now let us have a look at pneumothorax. Pneumothorax means air in the pleural cavity, means it will be black. Even in expiration, the pneumothorax, it will not, the air is not going out, the air will still be there, so it will appear black. So it will be black on both inspiration and it is expiration. Okay, so now look at the finding. Okay, look at the finding. So in expiration, your pneumothorax is black. In expiration, the lung becomes white. So the white lung gives a good contrast to the surrounding black pneumothorax. In inspiration, the pneumothorax is also black. The lung is also black. So black and black together, you won't be able to differentiate very easily. If you make one thing look white and the other thing look black, then you can identify them easily. Okay, then you can identify them easily. So that is why in expiratory view, the white lung gives a good contrast to the black pneumothorax. While in inspiration, both of them are black. So black and black together, you won't be able to differentiate. Okay. So this is what is the concept of your expiratory view in pneumothorax. Similar to foreign body, any obstructive pathology, basically, you will do expiratory view to look for air trapping. What is air trapping? Expiratory view mein the lung is not becoming white. That tells you there is air trapping. The same concept we apply in your HRCT as well. In HRCT as well, we take your expiratory scan to look for the air trapping. To look for the air trapping, we do the expiratory scan basically for your obstructive pathologies. Okay, so if we see air trapping, we know that there is an obstructive pathology component to it. Okay, there's an obstructive pathology. All right. So this was about, I think, yes, those were the cases that we had for today. So the 5 cases that we saw in pediatric radiology. First one, neuroblastoma, calcification, midline crossing and skull metastasis. Then we saw your pneumoperitoneum, the football sign in the center. You have the ligament. Then what was the next that we saw? We saw basically 5 cases. एक देखा Meconium Peritonitis, where you see the calcification, meconium going out, distended bowel loops. One we saw the foreign body, expiratory view, and one we saw बीच में कौन सा था, that was your Shimitar, right? That was your Shimitar sign or the Shimitar syndrome. Okay, Shimitar sign or Shimitar syndrome. Now you can also tell me that one final question that I want to ask you. In the foreign body, we said that take an expiratory view. If the child is not cooperative to do the expiratory view, the child is too small, then what can you do? What can you do in that case? Any other view or anything else that we can do? If the child is not cooperative, the child is too small, not cooperating for expiratory view, then what can we do? No. So if the child is uncooperative, then we do a decubitus X-ray. Okay, then we do a decubitus X-ray rather than directly going for bronchoscopy. How will decubitus help? Decubitus, when you do the decubitus, that side lung, because of the pressure, it should collapse. Matlab, the volume should decrease. If the dependent lung is not decreasing in volume, that means that it is obstructed. So the decubitus means if the lung is not decreasing in volume, then it is your obstructed side. Yes. How to differentiate from pneumothorax? So Chandra Reddy, pneumothorax is something. Just a second. Pneumothorax is your outside. You will see the visceral pleural line. You will not see the bronchovascular markings. While your lung will show the bronchovascular markings. You don't have the visceral pleural line separately that you will see in an obstructed lung. Okay. So even if you see here, you can see this white lines through the lung. So that tells you that this is a hyper-expanded lung rather than the pneumothorax. The absence of bronchovascular markings and the visceral pleural line. These are the two signs. Okay. So yes, that's about this, guys. That's about this session. I hope you have enjoyed this session. Do let me know in the live chat and in the comments as well if you're watching the session later on. Would you like to have more such sessions, the interesting, extra edge, out of the box radiology cases which help you clear the concepts basically. So yes, definitely. So alright, thank you so much. So I see quite a few of you who have enjoyed these sessions. And if you are not very strong in radiology, guys, you can definitely watch the plus sessions that we have taken with all the concepts in radiology. Why something is black, why something is white, where do you see what sign, and why do you see a particular sign. That will help you clear the concepts. Alright. So till then, goodbye and take care. We'll come up with more such sessions. And that's for today. Goodbye. Take care. Keep studying. Keep revising.